في الأول أنا أحب أبارك لقسم الطب الطبيعي والروماتيزم والتأهيل بجامعة عين شمس لإخواتي وزملائي على نجاح المؤتمر، وبتمنى لهم الاستمرار دايما في النجاح لنجاح. وأسعد إن أنا أكون موجودة في البانل اللي هيكون فيه الأستاذي ومعلمي ومؤسس القسم في القصر العيني أستاذ الدكتور سمير البدوي في النهارده، وبنستأذن أستاذنا إنه يتفضل بالمحاضرة الأولانية.
Let me start by thanking and congratulating Professor Malik Ganzouri, Professor Nagwa, and Professor Inez for a very successful meeting. Really, we are extremely happy being part of this meeting, and really it is a pleasure to be here today. Thank you very much, Iman, for your nice introduction. And let me start by saying that my topic today is osteoporosis medications. When to continue and when to stop. This is a frequently asked question, not only by physicians, but the patients. The patient's first question is, how long should I take the medications? And what happens if I got a fracture? And what are the side effects which are likely to occur? So I want to address this because this is a real life scenario of what we have. There are many definitions for osteoporosis. There is an osteoporosis definition by the IOF, there is an osteoporosis definition by WHO, but this is the definition I really like. We know that osteoporosis means porous bone. The bones are, this is the normal architecture of the bone, and then the bones become osteoporotic. They lose the stresses, especially the transverse ones and the longitudinal ones, and then fractures will occur. And when they become porous, any minor trauma will lead to a fracture, and the fracture risk is increased as the disease progresses. This is a very silent disease, and suddenly the patient will be faced by a fracture. And I remember many years ago when a rheumatoid arthritis patient told me I have pain in my back, I keep telling him rheumatoid arthritis has nothing to do with the back. You may have lumbar spondylosis or whatever. But at that time, we didn't realize that the patient can have a vertebral fracture. It starts with a macrofracture, and then the macrofractures get together and eventually leads to wedging of the vertebrae. And this is something we see commonly in our patients now with rheumatoid arthritis, especially after the use of glucocorticoids. So this is a symptomatic disease, and this is the normal architecture, and then when it becomes thin, porotic, and collapses, and this is what goes on. We know that this is a prevalent disease. This disease was an orphan disease. We never spoke about it in the past because it's a multidisciplinary disease, and whenever you have a multidisciplinary disease, it is an orphan disease. However, because in Europe and in the States they found that there is a high prevalence of fractures secondary to osteoporosis, so we can say that it affects almost 200 million people worldwide. This is going to double within the next 50 years, especially the hip osteoporosis and fracture hip. 22 million women and 5.5 million men in 27 member states of the European Union have the disease. What about the prevalence of the disease in Egypt? I would like to show you this at the base of this table, that at the age of 80 to 84, 25% of the patients get osteoporosis and get osteoporotic fractures, especially in women. So this is a disease which is underdiagnosed, under treatment, and at the same time, 1/3 of the vertebral fractures don't come to our attention because, as I mentioned before, it's a microfracture. The microfractures getting together, and then they will lead to wedging of the vertebrae. 80% who have already osteoporosis already have one osteoporotic fracture, which either occurred noticed or not noticed or not treated. And the evidence suggests women will sustain a high fragility fracture and are not diagnosed and not properly treated. So this is a debilitating disease, and I always say this disease starts with the embryo inside the uterus of his mother. If he does not have enough calcium and vitamin D from his mother, if he does not lay sound bones, if he does not lay bones which can resist fractures, when he grows, he will get rickets, and as time goes by, he can get osteomalacia and osteoporosis. There's one fracture occurring worldwide every 3 seconds, and the sequence of events, if a woman gets a fracture, her likelihood to get another fracture goes from 1 to 3 to 8 and so on. This is a disease of women because of childbearing, but it is not mainly due to the childbearing. It is mainly due to prolonged lactation, which is prevalent in this country till now. Because many of my patients who are females who give birth, they will keep continuing lactating and breastfeeding their children till the age of 2 years. So the prevalence of vertebral fractures in Egypt is almost 20.5% in the Egyptian women. And as you can see here, it's almost 24% all fractures occurring respective. It is in the wrist, it is in the hip, or it is in the spine. The hip fractures are very important because the hip fractures can lead to disability. And it is projected that in Southeast Asia, within the next years, from now till 2050, the number of hip fractures will increase from 1.6 million to 4.5. This means that it's almost to be tripled. After the hip fracture, 40% of the patients are unable to walk independently. At the same time, it is associated with chronic pain, reduced mobility and disability. 60% will require assistance a year later, and the worst part of it, that mortality occurs in 20 to 24% of the patients without unknown cause following a hip fracture. So this is a disease which has a burden. Reduced quality of life will lead to increased disability caused by chronic pain, reduced height, increased independence, and lower self-esteem. The patient is not confident to walk alone because he will fall, leading a sedentary life. Patients don't want to walk, and this will lead to sarcopenia, and muscle weakness and sarcopenia will lead to future fractures. There is an increased economic burden because the patients will go into hospital, they will have surgery, they will stay in the hospital for a time, and then they will have physiotherapy, which is higher than the cost of cancer, except lung cancer. Spent in the hospital days are increasing, more than myocardial infarction, and 1/3 of the hip patients who have fractures will go to a nursing home to look after them, and mortality is high. This is the bone remodeling cycle. There is what we call coupling. Osteoclast has to come to the scene, and they will demolish the old fractured or minutely fractured bones, because we have the osteocytes. The osteocyte is the most important cell in the skeleton of the body, because they have mechanoreceptors which reach the surface. Microfractures occur, so they will lead to recruitment of osteoclasts. Osteoclasts will form a pit, and then after that there will be osteoblasts coming in, lining the surface of the bone, and eventually it gets calcified. So we have a new osteoid, we have a new bone, and then we have a cement line which is between the old bone and the newly formed bone. But what happens in osteoporosis, that there is micro cracks which occur here, and these micro cracks leads to fracture because they cannot bear the weight of the body or the movement of the body, and so they fracture. What I'm going to speak about today, I have 5 topics here. Which medications do we have till now? When to continue the medications, when to give the patient a drug holiday, when to stop and take away message. These are the drugs which we have so far. We have drugs which inhibit bone resorption, which we call anti-resorbatives or anti-remodeling. It includes alendronate, bisphosphonates, generally speaking, diazonamab, raloxifene, salmylcalcitonin has not been used now, and estrogen. And at the same time, we have a bone anabolic drugs which build up bones. We have teriparatide, apaloparatide, and we have romosozumab, which I hope one day we'll have it in this country. So the action of the anabolic drugs, it stimulates remodeling, it recruits more osteoblasts, and the net will have a new bone. And these are the osteoblasts coming to the surface, putting new bone, laying new bone on the pit which has been destroyed or resorbed by the osteoclast. And this we have the teriparatide, which is a pH analog. It's 20 micrograms daily. And we have apaloparatide, which is a PTH receptor protein analog. Its dose is 4 times the dose of teriparatide, so it is 80 micrograms per day. And then we have the anti-resorbative drugs. And the function of the anti-resorbative drugs is to slow down the osteoclastic activity, sometimes leading to apoptosis of the osteoclasts. And we have here bisphosphonates, irrespective if it's oral or intravenous. We have raloxifene, which is a selective estrogen receptor modulator. And then we have the diazonamab, which is anti-rank ligand. And this is the treatment approach. This is the resting phase. The patient has healthy bone, nothing have occurred, and then there is a microfracture occur. The microfracture will lead to rank activation and rank ligand, and this is the osteoclast with the rank on the outer surface of the cell, and the rank ligand will deck here, and when it decks, it will lead to activation of the osteoclast. There is another mechanism by which is osteoproteogrin is produced by the osteoblasts, and this is a decay receptor which you can dock here and prevents activation of the osteoclast. Once the osteoclast becomes activated, there is a pit, there is a new bone formation, remodeling, you can use diazonamab, you can use bisphosphonates, and then this process is reversed, and eventually new bone has been laid, and the bone lining cells come here, and there is mineralization, and then it goes to the resting phase like it started here, and so on. So we have bisphosphonate and diazonamab. Bisphosphonates bind to bone, they inhibit the osteoclastic activity, and sometimes cause apoptosis of the osteoclast. It's an oral agent, 20% had gastrointestinal side effect, inconsistent absorption, because it has to be taken on an empty stomach to allow its proper absorption, and you can monitor the bone turnover markers while you are giving your patient the bisphosphonates. It's excluded from patients with chronic kidney disease, because if you have a creatinine clearance less than 30 milliliter per minute, you cannot give it. We have the intravenous zoledronate, which avoids gastrointestinal effects, but at the same time, it causes flu-like illnesses, and I have patients who have been admitted to the ICU in the middle of the night after taking the intravenous bisphosphonates. At the same time, we have the diazonamab, which causes more increase in the bone mineral density than the bisphosphonates. It can be used in chronic kidney disease because its secretion is not from the kidney, it is from the reticuloendothelial system, and when it stops taking the drug, there is increased rate of vertebral fracture. The American Society have ASUPMR, which is the American Society for Bone and Mineral Research. They came with this algorithm that for postmenopausal women, you can give oral or intravenous bisphosphonates. It's 2 years, 3 years, or 5 years. And then if the patient is doing well, and if there is a fracture which occur, reassess the benefit. And because your diagnosis may be wrong, reassess the risk factors, and either to continue or add or change to another anti-resorbative or anabolic agent. If the BMD decreases, there is a high fracture risk, and this, if it occurs, reassess again and change to another alternative therapy, for example, diazonamab with a different mode of action. And if the patient continues without having any fractures, consider drug holiday from the disease. This is a very important chart. This is what the FDA came, approved osteoporosis medications. We have to differentiate between prevention of osteoporosis, treatment, steroid-induced osteoporosis, and the osteoporosis in men. Alendronate, the oral one, prevents postmenopausal osteoporosis, treats postmenopausal osteoporosis. It does not prevent glucocorticoid-induced osteoporosis, but it does treat glucocorticoid-induced osteoporosis and male osteoporosis. Risedronate, which is another bisphosphonate, it's a sodium bisphosphonate. It prevents postmenopausal, treats postmenopausal, prevents steroid-induced osteoporosis, and treats steroid-induced osteoporosis and treats male osteoporosis. Ibandronate, we don't have it. Zoledronic acid, the same like alendronate. Raloxifene, we don't have it, but it prevents postmenopausal and it treats postmenopausal osteoporosis. Estrogen, you have to use it in a very short time because after the Women Health Initiative study, which included almost 35,000 patients, there's an increased risk of VTE and at the same time strokes. Desanumab, it treats postmenopausal osteoporosis. It treats glucocorticoid-induced and male osteoporosis. Teriparatide and apaloparatide, they are anabolic agents, and whenever you are stuck with any of these, you can use teriparatide or apaloparatide. So how long to treat? This is a very interesting question because the patient will ask you, how long should they stay in the treatment? Hormone replacement therapy, as short as possible. This is according to the FDA and the EMA. Bisphosphonates, controversial. 3 years, 5 years, some people go up to 10 years. Raloxifene, there is no limitation because it does not have side effects apart from venous thrombotic events, but you can monitor it. Teriparatide and apaloparatide, 24 months, and now they are considering 36 months for glucocorticoid-induced osteoporosis. Denosumab indefinitely because when you stop denosumab, the fractures will increase. Now the second topic is when to continue medication. We started with studies. Drug companies, when Max Sharp started with the alendronate, the Fosamax, you remember it, they said, use it for 2 years. The patients will get better and you stop the treatment. And then after a while they said, no, use it for 5 years. And then use it for 10 years. And so this is why we get these studies, they are old studies. The old one is the FIT study, and the FIT trial included, this is a fracture intervention trial, almost 4,000 women, postmenopausal osteoporosis. The primary endpoint was the effect on the mineral density and fracture risk, and the mean follow-up was 3.8 years. They took one arm of this study, and they did what they call FLEX study, which is long-term extension of the FIT. They took almost 1,000 women with postmenopausal osteoporosis, extended the 5 years to 10 years. The primary endpoint was the total hip after 10 years. Second endpoint was the immediate idle sites and biochemical marks. Be aware of one thing. All the anti-absorbatives increase the vertebral bone mineral density. Occasionally, they increase the hip. But with old age, we are prone to have hip fractures more than vertebral fractures. And this is the FLEX study. They took the FIT, they took number of patients, almost 1,000 patients, and they asked them to continue for 10 years. So the aim of the FLEX study was to compare the changes in the hip BMD between women who had the drug for 5 years and those who extended to 10 years. It is a double-blind randomized trial, and participants were almost 1,000 patients. The post-hoc analysis of the FLEX showed that no fracture was not predicted by 1 year change in hip bone mineral density. You can have the increased bone mineral density after 1 year, but this does not prevent the fracture occurring. 1 year change in N-teleoptide, which is PINP, which is a bone marker of bone formation. 1 year change in bone-specific alkaline phosphatase, New fractures were more likely if the femoral neck T-score is less than minus 2.5 and the person had more than 3% greater decline in the total hip BMD. Then came the hyaluronic acid, and they had the Horizon study. And the Horizon study was 3 years to start with, and they extended it to 6 years. So they had, the patients have 3 infusions for 3 years, and then they split the patient in 2 groups. They extended it up to 6 years. And after 6 years, they found that there's a decrease. This is the 6 years, the decrease in the morphometric vertebral fractures. And those who continued 6 years, at the same time, similar risk of non-vertebral fractures if they continued for 6 years. So the whole idea came to the fact that the longer you take the medication, the better you can prevent fractures, but this is not the rule. So these are 3 large studies, the FIT, the FLEX, and the Horizon. They were controlled, randomized. They included more than 14,000 patients and 51,000 patients year of follow-up because they extended to 10 years. The FIT has postmenopausal osteoporosis, and the age was more than 65 years. And the FLEX was 1,000 patients. Patients were given alendronate for 10 years, and the Horizon intravenous bisphosphonates for 3 to 6 years. Then came the desumab, and they started with the Freedom Extension study. They started to give the patient 60 milligrams subcutaneously every 6 months and placebo. And the placebo here is not placebo, it is vitamin D and calcium. You have to be aware of this. And then they extended it up to 10 years. So we started with 5 years, and they continued up to 10 years. And the outcome of this study was that there is a rheumatologist called Dr. Kosman who came in from the States, and he said, I'm going to classify and stratify my patients according to the life stage. He said, early postmenopausal women without a fracture, estrogen, selective estrogen receptor modulator, or both. If a woman at the late 60s and beyond without a fracture, oral or intravenous bisphosphonate, monitor the holiday with bone mineral density. Women in late 60s and beyond without fracture, but with major risk factors like family history, or taking glucocorticoids, or having rheumatoid, oral bisphosphonates for 3 to 5 years, or denosumab, and women at any age with recent fracture, multiple fractures, anabolic therapy like teriparatide and apaloparatide should be considered. The next part of my presentation, what is a drug holiday? We know that bisphosphonates have a long terminal half-life, similar to that of the bone. They can stay up to 10 years. Underneath the bone, it remains inactive. But when the bone remodeling occurs, they become activated. They go to the surface, they go to the osteoclast, and they start declining the activity of the osteoclast and obtuse. And this is why the skeletal effects of bisphosphonates may last for years after the treatment stops. And this is why the side effects might continue. They raised the issue about the possibility of stopping therapy and avoiding adverse events, because the more you use the bisphosphonates, the more you will get side effects. So they started to think about drug holiday. The first person who did the study on drug holiday was someone from South Korea. He said, I'm giving my patient treatment for a long time, I'll stop it for a while. And this is the bisphosphonates underlying the bones. At the same time, when there is inhibition of osteoclast, they will start to function. They can lead to apoptosis, allowing the osteoblasts to work unchallenged and lay new bones. So we want to give a drug holiday. Most of the benefit comes after 3 to 5 years. Zoledronic acid, even 5 years, but usually after you give the patient your treatment for 2 to 5 years, still consider a drug holiday, but not for every patient. You have to monitor the patient. 10 years with the denosumab data, this is the old data, 3 years with the teriparatide and the apaloparatide, and at the same time, romosozumab, which is Evenity, we don't have it here in this country. What about the safety concerns? Because the more you give the drug, the more the side effects will occur. Osteonecrosis of the jaw is one, a typical subtrochanteric fracture, especially after 5 to 6 years, and the risk returns after 1 to 2 years, even after stopping the drug. So the rationale was the fact that the patient have acquired a bone mineral density. It has increased, and he still has bisphosphonates in his bones, which is going to be active for another 10 years. So even if I stop the drug for a holiday, still the patient is going to acquire new bone. But this is not the true story. What happens? The drug holiday may reduce the risk of osteonecrosis of the jaw and the atypical femoral fractures. It can be variable based on every individual patient, the age of the patient, demographic, previous history, risk factors, and so on. And so, not all holidays are equal. Binding affinity to the bone is highest with hyaluronic acid, and it is less with. أنا خلصت؟ Okay. So what are the problems with the bisphosphonate holiday? Patients with rapidly declining BMD and T-score may be at risk of related factors. And this is why when you stop the patient from taking alendronate or bisphosphonates, do the bone turnover markers after 3 months. The old recommendations by IOF was to stay for 1 year and then do the BMD, and by that time the patient may have fracture. So if you do the bone turnover markers and you can see that the patient is losing bone quickly, you can reinstall your treatment or switch to anabolic drug. The bone turnover markers are very useful for holiday decisions in bisphosphonates holiday. It correlates with the BMD trends during a holiday. The validation will show us the threshold of increase or to identify those with a risk of holiday. Drug holidays are not drug retirements. You are not stopping the drug because you are not going to go back. You can go back to the drug. These are the bone turnover markers, and the one we use, the recommended by IOF, is pro-collagen type 1 terminal peptide, PINP, which denotes bone formation, and C-terminal CTX cross-linking telepeptide, which denotes bone resorption. So consider if you have a low fracture risk, 5 years of alendronate or 3 years of zelodronate. And this, if you are sure that the patient has acquired and a good bone mass, he does not have a fracture risk, prior compression during therapy, it's very important not to give a drug holiday. And if the patient is still on glucocorticoids, weight loss, or cancer therapy of frequent fall. If the patient remains at a high fracture risk, continue or switch. No safety data for more than 10 years. We don't have any data. Monitor the bone density and ask about fracture, and resuming the therapy if the frax is okay. But at the same time now they have combined the frax with the TBS, trabecular bone score, which gives us more insight. This is what happens when you stop dizanumab. After the continuation of therapy with dizanumab, rate of fractures increased by 7.1% per 100 participants per year, and of the participants that developed one fracture, rate of multiple fractures was high. So we can say that why should you stop denosumab? Safety concerns, lack of safety after 10 years, patient preference, patient doesn't want to have injections, non-compliance, patient is missing doses, side effects, and the most important side effect is hypocalcemia. Before starting any anti-resorbate or starting denosumab or anabolic agent, you have to do the serum calcium. Atrial fibrillation can occur, and then osteonecrosis of the jaw and ongoing bone suppression. So denosumab holiday does not exist, is not recommended. Upon stopping denosumab, there is notable rebound in remodeling. DO values higher than pre-treatment levels with rapid loss due to the risk rise in bone resorption markers. When you stop, some of the osteoclast which has been suppressed will become activated and will lead to more resorption. The rapid bone loss and the increase in bone markers has been associated with an increased risk of multiple fracture, of vertebral fractures, and according to the data we have, we should not stop without considering alternate therapy. The old regimen was 5 years, 10 years, but now if you stop this ROMAP, you have to shift to another, either anabolic or anti-resorptive drug. When to resume therapy? As I mentioned, drug holiday is not a retirement. The drug holiday continue on the baseline recommendations, exercise, vitamins, and so on, assessment by DEXA, I would say every 1 year, but bone turnover markers before, continue the risk factors, consider the bone turnover markers, and consider reinitiating therapy if the BMD score goes less than minus 2.5, decrease more than 3 to 4%, new fracture occurring, new additional risk factor, and major increase in the bone turnover markers. So the possible benefits of drug holiday as you avoid gastric irritation caused by bisphosphonates, subtrochanteric fractures, osteonecrosis, and taking the medications once weekly, clinical visits, and reduced medical cost, laboratory studies, and support. The possible harm, a new fracture occurring, decline in the bone mineral density, and you lose the patient for follow-up, and reduce the adherence to bone life, healthy style life like exercises, nutrition, stopping tobacco, and stopping alcohol. So if we weigh the benefit of bisphosphonates holiday, you can see that if there is an increased risk of fragility fracture, don't give a holiday, but if there is a reduced the typical femoral fractures, and osteonecrosis of the jaw, it is okay. So how to monitor the drug holiday? Continue healthy lifestyle. Patients should report fractures, screen for silent compression fractures of the spine, and the bone turnover markers should be done every 3 months, and periodically remeasure the bone mineral density. When to stop medications? When you have side effects. Atypical femoral fractures is a risk of long-term anti-resorptive therapy. And these fractures, they are rare, but however, they occur. Orthopedic surgeons see most of it. It's low energy or spontaneous, subtrochanteric, usually in the femur, thickened lateral cortex, over in the tibia of the femur, transverse or spiral fracture. Break is associated with stress fracture. At the same time, thigh pain. And any patient, you have to ask the patient specifically who are taking anti-resorptives if they have thigh pain or not. And over 5 to 10 years, use it as well as the Xenumab. And this is the site of the fracture here. And you can see sometimes it goes like this. It has been reported first in 2005 in patients receiving oral bisphosphonates. Occur with little or no trauma, and age-adjusted incidence suggests a duration-related disease, an increase in the bisphosphonates or anti-resorbatives. 2-year exposure, we have 1.8 per 100,000 per year, and 8 to 10 years, the number increases to 113 per 100,000 patients. This is a case, and this patient has been on anti-resorbatives. He was taking alendronate. In September 2008, he had an X-ray, and the X-ray showed normal. There is nothing in the X-ray. And then in May 2009, after almost less than 6 months, there is increased here in the shaft of the femur. And it showed that there is thickening of the cortex of the shaft of the left femur, slightly more than on the film in 2008. So it was diagnosed as stress fracture. Did a CT in June 29, and the CT showed the thickened cortex secondary to atypical fracture. So if we weigh the risk versus the benefits, the fracture can occur in 8 out of 10,000 patients. But the number needed to treat with 3 years to prevent hip fracture is 9 to 1, to prevent radiographic vertebral fractures 14. The number needed to harm with a typical fracture is almost 417 in 100,000 patients. For each stress fracture caused, at least 30 vertebral fractures and 5 hip fractures are prevented. So what happens if you have a typical vertebral femoral fracture? Stop the anti-resorptive medications, osteoanabolic agents, then what? Either to give the patient raloxifene or teriparatide. Now the other side effects from alendronate is osteonecrosis of the jaw. And osteonecrosis of the jaw, it has been described first in 2003 in patients receiving high dose of intravenous bisphosphonates, and the incidence is 1 in 10,000 to 1 in 100,000 patients, which is a huge scale. Appears to be trend towards osteonecrosis with duration of bisphosphonate use, and at the same time, the American Dental Association reports that the sound oral hygiene practices, regular dental care can prevent osteonecrosis of the jaw. And I remember in one of our meetings, I asked one of the dentists to give us a presentation about bisphosphonates and oral and osteonecrosis of the jaw, and we felt, all of us, that we are criminals because he showed us the disastrous things we see. I personally haven't seen any patient with osteonecrosis of the jaw. It occurs in almost 5% of the patients, especially cancer patients, who receive high dose of bisphosphonates, like the Zomit. The risk of bisphosphonate is estimated to be 1 in 100,000 patient treatment per year. A review of 44 cases in 2008 describing 481 patients with bisphosphonate-related osteonecrosis of the jaw found that it's more common in patients receiving intravenous bisphosphonates. It's over 90% of patients who had cancer, and approximately 31% of the patients had prior use of glucocorticoids, and the 68.8 cases after surgical or invasive dental procedures. 93%, 20% of the patients developed osteonecrosis of the jaw, and recently it has been shown that osteonecrosis of the jaw can occur with desonumab as well. And this is how it looks like. This is the current definition. Exposed area in the maxillofacial area. Pain can or cannot be present, and the diagnosis, there is no evidence of healing after 8 weeks of appropriate evaluation, no evidence of metastatic disease in the jaw or osteonecrosis. So I took you through a journey where I described which medications do we have, when to continue medications, what is a drug holiday, and when to stop the medication. It's time to say my take-home message. DEXA and FACS, they are opportunity to sterify our patients. 1 in 2 women and 1 in 5 men over the age of 50 years worldwide will experience an osteoporotic fracture. Osteoporosis should be treated because of its disability, impact, early diagnosis if feasible, and many drugs are available now. Before that, before the DEXA, we used only to have plain X-rays, lateral views of the spine, and by that time, if it shows osteoporosis, the patient has lost almost 30% of the bone mass. Treatment strategy should be set for every individual patient, when to continue and when to stop. Osteoanabolic agent should be considered as an initial treatment in very high-risk patients. Lab evaluation is important for secondary causes prior to routine osteoporosis treatment. Dietary calcium and vitamin D supplementation are essential, but may not be sufficient. And finally, 2 questions I leave for you to think of. Is chronic administration of drugs essential? And the second question, is chronic administration of drugs safe? And before you consider giving your patient treatment, please assess the risk factors, the serum calcium and vitamin D levels, and ask the patient to modify his lifestyle, stop smoking, and do exercise. Thank you very much. خلوا أسئلة في الآخر ولا؟
As you like, Professor.
أنتوا
Thank you very much for your highly scientific presentation, and it's a very important topic. If you want the questions now, please be seated. Okay, yes. The floor is open for any questions for Professor Samir. Okay. It's my pleasure to present Professor Omar Hussein, Professor of Radiology, Ain Shams University. for his presentation, association between sarcopenia, rheumatoid arthritis, osteoarthritis, the importance of early radiological diagnosis.
مساء الخير جميعا. اولا بهنيكم على المؤتمر الجميل بتاعكم وبشكركم على دعوتي للمشاركه فيه. وانا الحقيقه الماركر بس بحس ان انا يعني في وسط اصدقائي واولادي واخواتي وكلكم يعني اصدقاء اعزاء من زمن طويل واتمنى لكم النجاح دايما يعني. لو انا عايز اعمل ماركر ايه بقى؟ هنا؟ ما بتبانش. أنا هتكلم على موضوع مختلف شوية اللي هو الساركوبينيا وعلاقتها بالروماتويد من هنا والأوستيوارثرايتس. With global population aging and increased longevity, aging and age-related diseases have become substantial burden and inevitable challenges worldwide. Especially in Egypt, where the population is expected to reach 165 million by 2050. Sarcopenia is a disorder involving the loss of skeletal muscle mass and function that commonly occurs with advancing age, as well as with number of long-term conditions, resulting in increased risk of fall and fractures, functional decline, multiple chronic diseases, loss of independence and frailty and mortality. Osteoarthritis, it affects over 250 million patients worldwide. It is the fifth leading cause of disability, and it has a bidirectional relationship between muscle weakness or sarcopenia and osteoarthritis. This relation, because of osteoarthritis causes joint pain and stiffness, and sarcopenia causes wasting of muscles, and both cause physical inactivity, leading to increased weight, reduced energy expenditure, and a vicious circle starts to be between muscle weakness and osteoarthritis. And here we have to interfere to break this vicious circle. Rheumatoid arthritis, as you all know, affects a big number of patients worldwide, and sarcopenia is believed to be more common in rheumatoid arthritis due to several factors, which are inflammation causing cytokines leading to muscle breakdown, pain and its impact on lifestyle, physical demands of the disease. So people with rheumatoid arthritis are more likely to have earlier onset and more severe sarcopenia. Early diagnosis is crucial because our role is to prevent the disease rather than treat it. Sarcopenia, early prevention by lifestyle modification, early osteoarthritis detection by early knee osteoarthritis concept to change the current reactive approach of osteoarthritis management to proactive one, and early rheumatoid arthritis using the disease-modifying agents as soon as possible. How to early diagnose each of them? Sarcopenia, we can use different techniques as DEXA, ultrasound, CT, and MRI. We will go through all these techniques rapidly with the concentration of early detection and early diagnosis. For diagnosing sarcopenia by DEXA, DEXA is advised by revised European Working Group on Sarcopenia in older patients guidelines for sarcopenia confirmation in practice. DEXA is not appropriate for measurements of the trunk and abdominal region. Unlike CT and MRI, we will come later to them. DEXA is very appropriate for axial skeleton. It's effective in appendicular or extremity skeletal muscle mass estimation. يعني DEXA نشوف فيها اللور limbs كويس، الأبر limbs كويس، لكن الترنك نعمله بالCT أو بالMRI. appendicular skeletal mass ده index بنحدده should be adjusted طبعا for body size either by height or body mass index لأن الماسل ماس مختلفة طبعا ما بين الهايت والبودي ماس اندكس من واحد لواحد. هذا الاندكس له cut values. The skeletal mass, appendicular skeletal mass is divided by square of height to obtain the appendicular skeletal mass index in kilogram per meter square. والأوروبيان جروب عملت اندكس ليها يبقى لو اقل من 6 كيلو جرام بير متر سكوير يبقى ان ويمن يبقى ده ساركوبينيك واقل من 7 في المن. وفي ايجيان بيبقى اقل شويه طبعا في المين وفي الفيميل 5.54 to 7. يعني احنا عندنا اندكس واضح وله ارقام كات اوف فاليوز نحدد بيه ان البيشنت ده ساركوبينيك او قرب للساركوبين. بنقيس الماسل كلها في الاطراف ونشوف بالنسبه للويت والهايت ونطلع الاندكس اللي هو بيحدد لنا زي مثلا البيشنت دي 4.5 دي ساركوبينيك بيشنت باستعمال نفس جهاز الدكسا بس برامج مخصوصه فيه بس هو نفس الجهاز بنسميها بودي كومبوزيشن بروجرامز. تاني حاجه في الدايجنوز الالترا ساوند. الالترا ساوند بتبين لنا حاجتين السايز والايكوجينيستي او التركيب. السايز it is a marker of muscle mass. الايكوجينيستي marker of muscle quality. يعني ممكن تبقى تخينه بس ضعيفه. Diagnosing sarcopenia, functional perspectives and new algorithm from كذا. Ultrasound imaging has been incorporated into the diagnostic protocols of sarcopenia. سواء بالماسل سايز او في حاله السايز هنا اكتر حاجه بترفلكت وجود الساركوبينيا اللي هي muscle measurements في الكوادريسبس. Changes in this muscle measurements can be seen as early as 6 weeks after beginning resistance training. يعني لما ببقى اعمل تريتمنت للساركوبينيا ممكن اعمل فولو اب بالالترا ساوند عشان اشوف الثيكنس بتاعها والايكوجينيستي in 6 weeks الاقي فرق. وده مهم جدا في المانجمنت بتاعها. دي الريكتاس فيموريس الانتيريور بارت بتاع الساي في الميدل ثيرد بنحط الترانسديوسر بالعرض ونشوف الريكتاس فيموريس السيكنس بتاعها وممكن نشوف كمان السيكنس على البودي ماس اندكس برضه لازم تبقى ريفيرد للبودي ماس اندكس عشان الحجم بتاع البيشنت والارقام تبقى اكتر من 1.4 او في الفيميل بتبقى اكتر من 1 يبقى نورمال. ده الميجرمنتس تاني وده مقاس تاني قليل للابنورمال وممكن اعمل سيركمفرنس كمان كله وليها برضه ميجرمنتس اخرى اللي هي المكتوبه الارقام اللي هي تحدد لي ان الماسل ماس قلت وده ميجر تاني للساركوبينيا. الايكوجينيستي كل ما الماسل الايكوجينيستي بتاعتها تبقى برايتر تبقى ويكر لانها فيها فات ديبوزيشن وفايبروزس. يعني النورمال بتاع اليونج ايج تبقى فليشي وهايبوكويك. اول ما تبتدي يحصل لها دراينس وتقل الفلويد فيها تبقى مور ايكوجينيك ويحصل فيها فايبروزس تبقى فيرزر ايكوجينيك. دي النورمال ودي الابنورمال ماسل اللي دي بقى تبين الكواليتي بتاعت الماسل. It is highly subjective. الماسل ايكوجينيستي عيبها بقى انها سبجكتيف. يعني ممكن الواحد ما يبقاش ظابط الجهاز شويه يقول لا دي ايكوجينيك واحد تاني يقول له لا ده انت مختلف معاه شويه. ودي سمه في الالتراساوند عموما يعني تعتمد شويه انها سبجكتيف على العين اللي بيشتغل يعني مش كوانتيتيف يعني بارقام زي المقاسات والسيركمفرنس بتاع الماسل او السيكنس بتاعها. وحكايه السبجكتيفيتي دي leading to poor comparability of muscle echogenicity فما بيعتمدش عليها قوي اكتر من اللي بيعتمد على المقاسات فعلا او السيرفيس اريا. ده نورمال ثيك وهايبوكويك وهنا نارود او ويك وايكوجينيك. نيجي على السي تي في الساركوبينيا. هنا بقى بيبين البودي كومبوزيشن اناليسيس كويس برضو قوي. السي تي عشان بيقيس فكره السي تي انه بيقيس دنسيتيز. الدنسيتي بتديني الشكل يعني لو هاي دنسيتي يبقى بون او ستون لو فيري لو دنسيتي يبقى فات لو ان بتوين يبقى سوفت تيشوز. ميزه السي تي عن الاكس راي ان في فاريشن كبيره قوي في الدنسيتيز فممكن اجمع عن كل مجموعه لوحدها واعمل لها كاركترايزيشن سواء ماسل او فات او بون او كريستالز ديبوزيتد. يعني اكتر حاجه بتميز السي تي اختلاف الدنسيتيز، فبتفرق لي الماسل تيشو، الفيسرال فات، سبكوتينيوس ادوبوس فات، وبكده اقدر اعمل مابينج لكميه الماسلز اللي في الجسم. مثلا لو احنا قلنا الماسل هنلونها، هو التلوين ده بناء على دنسيتيز معينه. انا بقول للجهاز الدنسيتيز بتاعه الماسل من كذا لكذا، حط لي عليها تاج احمر، والفات مثلا حط لي عليها اخضر. فانا لما ببص على الصوره الاقي هنا الماسل ماس كبيره قوي ريلاتيف لده، وده يبقى ساركوبينيك وده يبقى نورمال ماسل بالك يعني. كذلك ممكن اقيس كل الماسلز اللي في الجسم، وممكن اعمله ليميتد بس للسوس ماسلز. ده طريقه تانية للقياس، والسوس ماسلز دايما بترفلكت قوي حاله الماسلز في الجسم. هنا بنشوف ترانك بقى مش زي الاكستريميتي في الدكسا. ادي مثال تاني، هنا الماسلز اوف ذا باك ثين وهنا بيج. برضه ليها على فكره يعني ليفلز وارقام محدده، بحيث ان انا اقول ان البيشنت ده اما اقيس البي ام اي بتاعته، اقيس اقول مثلا الميلز ادي الكات فاليو بتاعها لو هو نورمال ويت، لو الهاي اوفر ويت يبقى الرقم المفروض يبقى اعلى شويه. Muscle assessment by CT could be done in routine CT examination as a biomarker of sarcopenia. يعني ما بعملش فحص مخصوص للمصل، انا بلاقي الفايندنج دي مع السي تي العادي، بس انا اعمل عليها فوكسنج واشوفها واشوف المقاسات بتاعتها واطلع منها الريزلتس. ودي بتبقى مفيده احيانا كتير قوي في الفريل بيشنتس او البيشنتس اللي في الانتنسيف كيرز او الحالات ايام الكورونا، ان احنا نشوف المصل او الدايابيتيك بيشنتس. المصل الضعيفه بتبقى جزء من البايو ماركر بتاع البيشنت مع الفايندنجز الاخرى بقى، في ايه في اللنج وفي ايه في الميدياستاينم وكده. يعني موجود الماسلز في الروتين اكس راي باينه، بس ما بتعلقش عليها روتينلي لان احنا دايما ما بنبصش عليها ومش متعودين نبص عليها. لايك سي تي ننقل على الام ار اي، هو يشبه السي تي برضه في الترنك، وبرضه بيبين الفات والفايبروزس والماسل فات اماونت. ات از سترونج بريدكتور تو لوس اوف موبيليتي. كل لما الواحد يكبر او يبقى عنده ويكنس في الماسل بيحصل ريبليسمنت للماسل فايبرز بفات، فتبقى ويك وممكن تبقى نفس الحجم حتى بس فيها فات كتير. مثل الام ار اي بقى انه بيفرق الماسكولار اماونت اوف فات كمان يعني. ودي سترونج بريدكتور تو لوس اوف موبيليتي. muscle fibrosis associated with decreased strength والاستيستي وبلاد سبلاي واتروفي اوف ماسل. يعني لما الاقي فيه فايبروز ده معناه ان الماسل فيها كل العيوب دي. ده الام ار اي ممكن يعمل هول بودي سواء ترانك او اكستريميتي، يجمع بقى ما بين الاكستريميتي بتاعت الدكسا والترانك بتاعت السي تي، وليها كات فاليوز برضو بمقاساتها للمين والفيميلز علشان يبقى عندنا ريفرنس مظبوط للساركوبينيا او دايجنوز الصريح ليها. لو احنا خلصنا الساركوبينيا ننقل على الايرلي اوستيوارثرايتس. دايجنوزس ايرلي ني اوستيوارثرايتس، طبعا الحاجات اللي هي معروفه كلينيكالي بيشنت كوشنير وكلينيكال اكزامينيشن وستاندردايزد ويت بيرنج اكس راي، كلنا عارفين الكي ال ديفينيشن بتاع الاوستيوارثرايتس وازاي بنقيسه في الاكس راي. بس احنا عايزين نبقى نسبق في الدايجنوز، يعني الايرلي دايجنوز ده اللي مهم دلوقتي، وخصوصا ان في ميديكيشنز كتيره بتعمل بريفنشن للبروجريشن بتاع الديزيز. يعني مش عايزين نستنى لما يبقى في لوس اوف كل الارتيكولار ديستانس راحت والحاجات الاتروفي خالص، المانجمنت بيبقى اصعب قوي. Radiographic findings may be normal in early stages of disease because cartilage is not directly visualized. طبعا في الاكس راي cartilage ما بيبانش، احنا بنشوف اللوس اوف جوينت سبيس بس. Radiography, although the first line diagnostic imaging modality is not sensitive to change over time and does not adequately visualize soft tissues. زي هنا الكي ال سكور مثلا، طبعا كلنا عارفينه لحد لما نوصل لكومبليت لوس اوف جوينت سبيس، بس ده متاخر قوي. وده الفرق مثلا ما بين اكس راي دي والثانيه بقى لها بعديها بسنه حصل فيها ناروينج. الام ار اي طبعا هو بقى اللي بيديتكت الايرلي ستيجز في الكارتليج. It's highly sensitive but not necessarily specific method. MRI is sensitive to detect joint tissue changes associated with osteoarthritis, but also structural changes commonly associated with osteoarthritis are very common in population, irrespective of joint symptoms. يعني ممكن يبقى في changes في الكارتليج بس لسه مفيش symptoms. MRI features of degenerative features changes of the cartilage, bone marrow lesions and or meniscus are based on the Boston Leeds Osteoarthritic Knee Scores اللي هي بتقول ايه بقى؟ يا اما في مورفولوجي سكور يا اما كارتليج سكور السيكنس بتاعه meniscal tear bone mineral lesions. كل ده بيبان هنا النورمال سيكنس بتاع الكارتليج وهنا حصل فيه اتنيويشن جامد على مدى سنه وفي منسكال بروتروجن هنا ابتدى يطلع والمنسكال بروتروجن ده احيانا هو ده اللي بيصغر الجوينت سبيس في الاكس راي والكارتليج بيبقى لسه سليم. يعني ممكن يبقى في منسكال بروتروجن والجوينت سبيس قل بس الكارتليج لسه سليم وده اللي فرق بقى ما بين الام ار اي والاكس راي. دي امثله بقى للفايندنجز اللي موجوده. وفي بقى الجديد ان احنا بنعمل ارتيكولار كارتليج مابينج نشوف الكارتليج نفسها اذا كانت هي المشكله في الكارتليج طب ما نشوف هو نفسه بقى. كان بي اسيسد كواليتيتيفلي سيمي كوانتيتيفلي اور كواليتيتيف باي سيمي اوتوميتد اور فول اوتوميتد ميثود. دي الحاجات الريسنت بقى في الام ار اي اللي هو بيرسم خريطه للكارتليج كله اللي على الفيمورال هيد مثلا الفيمورال كوندايل ويشوف التخانه بتاعتها اذا كانت نورمال او لحد لما تبقى راحت وفين الجزء بتاعها. ده اكزامبل اوف فيمورال كارتليج سيكنس ماب. دي الحاجات الجديده بقى اللي هي المفروض ان احنا هنبتدي نستعملها. هي في بعضها ابتدى يبقى في الماركت وبعضها لسه اكسبيرمنتال هنعدي عليها دلوقتي لكن هو ده المستقبل الحقيقه ان احنا بريفنت الديزيز. في مابينج للكارتليج بيبين في الاول خالص لما بيحصل ديجنراتيف ديزيز بيحصل لوس اوف كولاجين اند بروتيوجلايكان ده او بيزود الموبيليتي اوف ووتر انتو الكارتليج فبيحصل اليفيشن اوف كارتليج ووتر كونتنت. يعني في الاول خالص بيحصل لها سويلنج ويبقى فيها الووتر كونتنت كتير قبل ما يحصل فيها ديجنريشن وبالتالي يحصل برايت تي 2 سيجنال فيها. ده النورمال كارتليج وده المابينج بتاعه. وهنا لما يبقى ابتدى يبقى في ميه كتير المابينج بتتعكس وده معناه انه ابتدى يحصل فيها تشينجز قبل لما يحصل سيننج واتروفي. ده الكارتليج مابينج. ده حاجه ثانيه برضو بتقول ان كارتليج proteoglycan is largely responsible for the high elasticity and resilience of tissue and can be targeted using turbo-weighted imaging. In vivo studies showed increased the cartilage values on osteoarthritic subjects compared to controls. يعني بعمل له خريطه واشوف كميه ده النورمال كميه الووتر اللي فيه ايه واقيسها وبالتالي اكتشف ان الكارتليج ده ابتدى يحصل فيه تشينجز بدري. طب الالترا ساوند له دور في الاوستيوارثرايتس. ميزته ان هو ريال تايم ما فيهوش راديشن ولا كونتراست. برضه بيبين structural changes of cartilage and meniscus. كان assess inflammatory changes زي effusion والsynovitis والhigh diagnostic performance for detection of medial meniscal extrusion. Positive findings are strong indicators of cartilage damage بس negative findings do not necessarily exclude cartilage degeneration. طبعا دي الفايندنجز اللي ممكن نشوفها في الالترا ساوند synovitis synovial hypertrophy effusion pulse دوبلر سيجنالز في الساينوفيوم كارتليج دامج منسكال دامج اوستيوفايتس. كل الفايندنجز دي ممكن تتشاف في الالترا ساوند في الاوستيوارثرايتس او ذا ني. ده شكل الكارتليج النورمال اللي هو التخين وهوموجينس وسموث وده في النهايه خالص لما يبقى تقريبا مش موجود والريجولار. في حاجات تانية بنشوفها زي مثلا اوستيوفايت هنا في ساينوفيال سيكنينج ولو في التهاب او اكتيف انفلاميشن يبان في الدوبلر كمان. السي تي في الاوستيوارثرايتس بيبين طبعا ترابيكولار ريموديلنج وسبكوندرال سيستس وبون سكليروزس الحاجات اللي خاصه بالبون اكتر. وتيشو مينراليزيشن. في اكستريمتي سي تي برضه في الحتت اللي هي بتشتغل ماسكو سكيليتال كتير قوي. مشكله السي تي ان احنا ما بنشوفش العيان وهو ويت بيرنج وهو واقف في الركب، بنشوف هو نايم، عكس الاكس راي مثلا احنا بنعمل وهو واقف. ففي اكستريمتي سي تي اللي هو زي ده ما بيبقاش موجود قوي الا في حتت اللي فيها مثلا طب ملاعب والحاجات دي، فبيبين الني كاني عامل لها اكس راي ستاندنج، بيبين الكارتلج ويبين الجوينت سبيس. يعني هنا مثلا ده سي تي نايم وهنا سي تي ستاندنج وباين الديستنس قد ايه. ده بقى اللي هو النورمال اكتر او الفسيولوجيك اكتر بتاع البيشنت. ولو معاها كمان ساينوفيال انفلاميشن او سيكنينج ده بيت سي تي بيبين الاكتيفيتي اوف ذا ديزيز. وفي الارثروجرافي طبعا برضه بيبين اذا كان دي فيه ديفكت في الكارتلج والكونتراست طلع منه جوه البون، سي تي ارثروجرافي. ده اكزامبل تاني ليه. لو احنا خلصنا الاوستيوارثرايتس نروح على الايرلي روماتويد ارثرايتس بالتكنيكس كلها. طبعا كلنا اوير بتاع الاكس راي وازاي بيبين سمول ايروجنز او مش سمول، بس ده بيبقى ليت ان ذا ديزيز، مش هو ده اللي يهمنا بقى. احنا الكلام ده بقى المفروض يبطل ما نشوفوش، لان احنا في حاجات جديده او مختلفه بيبين الديزيز بدري. والحقيقه يعني في الواقع الاكس رايز اللي فيها الايروجنز الكبيره والديفورميتي واللوس اوف جوينت سبيس ما بنشوفهاش كتير دلوقتي نتيجه المانجمنت الجديد والحديث والتدخل الميديكال الجديد اللي بدري يعني اللي بيمنع البروجريشن اوف ذا ديزيز. الام ار اي more sensitive طبعا in detecting erosions in the hand and wrist in early rheumatoid arthritis than ultrasound and conventional radiography. It correlates with poor long-term outcome. بيبين تينوساينوفايتس اللي هي ساين مهمة قوي اللي هي هنا حوالين التندون في برايت سيجنالز. بيبين الايروجنز زي هنا. بيبين الافيوجن والساينوفيال هايبرتروفي اللي جوه الافيوجن. بيبين ايروجن وافيوجن وفي حين الاكس راي تقريبا نورمال. الالترا ساوند برضه بيبان مهم قوي وسهل. ساينوفيال سيكنينج، ساينوفيال افيوجن، تينوساينوفايتس، ايروجنز، كل الحاجات دي بتبان بالالترا ساوند واكسسبل وممكن اعادتها والفولو اب بيها اسهل من ان انا اعمل ام ار اي ويز كونتراست. يعني برضه امثله ثانيه ده ايروجن، بوني ايروجن وساينوفيال هايبرتروفي، وادي باور دوبلر بيبين فاسكولاريتي في الهايبرتروفي ساينوفيال. يعني الالترا ساوند في الحقيقه في الروماتويد ايرلي وفولو اب مفيد جدا. يعني السي تي infrequently used for the evaluation of early rheumatoid arthritis primarily due to the use of ionizing radiation and also because of its limited soft tissue contrast. الروماتويد احنا اكتر الحاجات كلها soft tissue، يعني ساينوفيوم وفيوجن وهايبرتروفيد وفاسكولاريتي ما هياش بون قوي يعني، عشان كده السي تي الحاجات الايرلي ما بيبانش فيها. Its major role is the assessment of cervical spines. السيرفايكال طبعا في السي تي مهم قوي لان ما اعرفش اعملها بالالتراساوند. Involvement in rheumatoid arthritis especially in the atlantoaxial subluxation and the fractures. It has a valuable tool for the evaluation of the pulmonary parenchymal involvement of rheumatoid arthritis. البيت سي تي برضه مفيد لانه بيديني مابينج لاني كل الجسم كل الجوينتس مره واحده ويقول لي مين فيهم اللي اكتف في اكزامينيشن واحده. اكزيال سي تي ثرو از ليفل اوف شولدر شولدر، ده اكزامبل مثلا باين اكتيفيتي في الشولدرز، وده هول بودي اهو البيت دي صورته كده فعلا، وده بيبين انا ممكن اعرف بقى فين، هل سيرفايكال، هل شولدر، هل هيب جوينت، هل ني تحت. في فحص واحد اعرف اعمل فين الاكتيفيتي في الجسم كله، وده مهم جدا. Final thoughts. Sarcopenia is becoming a critical public health burden compounded by an expanding early population. It has an intertwined relationship with osteoarthritis where both exacerbate each other in a vicious circle. Rheumatoid arthritis, chronic inflammation is a key driver leading to sarcopenia. Sarcopenia, osteoarthritis, and rheumatoid arthritis. Early intervention is the key for better outcomes, and this necessitates early clinical and radiological diagnosis. Thank you.
الحقيقة thank you so much دكتور عمر for the very elegant and comprehensive talk. احنا بصراحة يعني حتة الساركوبينيا دي طبعا دي we are deficient فيها كلنا، ونفتح بقى الفلور للكويشن. حضرتك اتفضل استريح. اتفضل حضرتك. هو أنا ممكن أبتدي الأسئلة؟ طيب اتفضل. طب في حد يجيب
شكرا دكتور عمر، شكرا دكتور سمير على المحاضرات الجميلة. دكتور عمر، عاوز أسأل زمان كنا بنعمل حاجة اسمها ماكرو اكس راي، مش عارف ده موجود دلوقتي ولا لا، وفي ايكو امبليتيود التراسونوجرافي بيقيس الايكونوجينيستي، ده موجود ولا مش موجود؟
ماكرو راديوجرافي موجود، ان احنا بنحاول ده ايام البلين اكس راي كنا بنحاول نعظم فايدته اكثر ما يمكن. كنا نعمل ماجنيفيكيشن للفينجرز والانترفالنجيال والميتاكاربوفالنجيال جوينتس بحيث ان انا اقدر اديتكت حاجه صغيره قوي. حاليا دلوقتي مع وجود التكنيكس الاكثر حساسيه بيقل بقى الاستعمالات بتاعه الاكس راي في الايرلي دايجنوز، ودي في الراديولوجي عموما كلها. يعني احنا كنا زمان التكنيكس مش افيلابل، فاللي موجود بقى بنحاول نكبر ونعمل توموجرافي ونعمل حاجات تانية كتيرة فوق الاكس راي نحاول نحسن ادائها. يعني ما عادش بقى دلوقتي عشان في حاجات تانية اسرع وبتخلص بسرعة. يعني
الايكو امبليتيود التراسونوجرافي،
الايكو امبليتيود التراساوند ده اللي هو الاي مود ده برضو اتغير. ده كان في بداية الالتراساوند كانت بيفرق لنا ما بين السوفت تيشوز والكالسيفيكيشنز والعظم. ايكو امبليتيود يعني الالتراساوند لما تنزل في الجسم بيحصل لها ريفليكشن، لو هي حاجه سوليد قوي الريفليكشن يبقى عالي، لو هي حاجه سوفت يبقى الريفليكشن واطي، وبيبقى في سبايكس كده. شكل الفحص سبايكس يعني زي رسم بياني. حاليا دلوقتي ريبليسد بالالتراساوند الهاي ريزوليوشن اللي هو بي مود. هو البي مود على فكره ده ايكو ريفليكشن، لو ريفليكشن قوي هيبقى ابيض، لو ريفليكشن بسيط هيبقى اسود، وان بتوين ده جراي سكيل.
انا فاكر سنه 86 انا عملت بيبر على الحاجات دي، استعملتها في السبورتس ميديسن، الهايبرتروفي والاتروفي باستخدام الايكو امبليتيود التراسونوجرافي، كان يهمني رقم.
ايوه الايكو امبليتيود بيطلع رقم لان هو سبايك. لو الماسل بقت فايبروتيك تبقى هايلي ريفلكتيف فالرقم بتاعها هيبقى عالي، لو الماسل سوفت يبقى الريفليكشن بتاعها بسيط فالرقم بتاعها يبقى واطي. بس حاليا بقى الحاجات دي غلط.
Okay, any other questions?
في الأول أنا بحب أشكر طبعا دكتور سمير ودكتور عمر على تشريفهم لينا، وحضراتكم قاعدين ومأخرينكم لحد دلوقتي، وده يعني معلش والبروجرام حضرتكم عارفين. أنا سؤالي هسأل سؤال صغنون لدكتور سمير وسؤال صغنون لدكتور عمر. دكتور سمير حضرتك فرصة بقى. دكتور سمير، هو حضرتك لما بندي الدينيزيوماب ويحصل البي ام دي توصل للنورمال، كان حضرتك اكيد حضرت سيرجي فيراري كان بيقول ان احنا ممكن نعمل مينتننس ندي زيلندرونيك اسيد once per year for 3 years. طب دلوقتي ما عندناش زيلندرونيك اسيد موجود، ففي ناس كانت بتقول ان احنا ممكن ندي الالندرونيتس for 1 year ونعيد تاني الدكسا، فايه رأي حضرتك؟
هو مشكله الديليزوماب انه اول ما نزل كان عندنا ستاديز على 5 and 10 years. بعد 5 years وقفهم فلقوا increased vertebral fractures. بعد 10 years وقفوا برضه لقوا vertebral fractures. انا شخصيا بشتغل على الكومبو اللي هو بدي في الهاي ريسك بيشنتس بدي تيريباراتايد مع ديزونوماب. العيان بيمشي على الديزونوماب continuously، بعد 2 سنين بيبطل التيريباراتايد وبيكمل على الديزونوماب. في كلام كتير بقى هنا. الانترافينوس زولودرونيك اسيد ممكن يتاخد، الانتي ريزورباتيف الندورينات الاورال ممكن تتاخد، ولكن العيان ما يتسابش بدون تريتمنت بعد ما نوقف الديزلوماب.
يعني حضرتك ترجح ان احنا دلوقتي ما فيش زولندرونيك اسيد، ندي الالندرونيس فور 1 يير ونشوف اورال ونشوف الدكسا بعد كده؟
انا ما بستناش الدكش، انا بعمل بيمتون اوفر ماركرز بعد 3 اشهر، لان العيان لو ابتدى يبقى فاست لوزر he's going to have a fracture. لانك لما بتدي دراج هوليداي بتقعدي 3 months ما بتديش دواء. لو هستنى سنه عشان اعمل بي ام دي في نفس الوقت ممكن يحصل فراكشر. فانا بعمل بعد 3 اشهر بيمتون اوفر ماركرز، يا العيان يبقى فاست لوزر يا اما ما عنديش lost للبون which I acquired. هي الفكره كلها انت you acquired a new bone mass. You don't want to lose it, لان if you lose it you will have a fracture and you will start the cycle again. فالبونتن اوفر ماركرز احنا للاسف في مصر ما بنستعملهاش كتير لان هي غاليه وبتتعمل في وقت معين من اليوم والى اخره. فمش هستنى سنه عشان الدكسا تحصل. مايند يو ان في عيانين في مصر هنا بياخدوا الزولودرونيك اسيد 1 سايكل وبيعتبروا ان دي التريتمنت ما بياخدوش تاني. العيانين التانيين ممكن يمشوا على البروليه 2 3 ويبطلهم وما ياخدوش حاجه، لان وي لوز ماني بيشنتس فور فولو اب. ويجي العيان بعد كده بهيب فراكشر، لان يعني هي جروز اولدر، الانسنس اوف فراكشرز زي ما بينت بيزيد، بيوصل 24% من الايدج 80 تو 85، وده الايدج اللي بيحصل فيه هيب فراكشر. والكومبليكيشنز بتاعته بتبقى mortality within the first year 20% of the patient. Whatever strategy you have after derazumab you have to fortify the bone mass you acquired، يا اما بالزولودرونيك اسيد يا oral bisphosphonates يا اما بانابوليك agents if the patient had a high risk factors.
شكرا يا دكتور سمير. دكتور عمر، حضرتك موضوع الساركوبينيا ده موضوع مهم جدا. حضرتك تفضل، احنا مش هنقول للعيان يعمل الحاجات دي كلها، فحضرتك اني واحد من الراديوجرافيك اسسمنت ده حضرتك تحب نعمله؟ وهل هو متواجد؟ يعني الدكسا البروجرام اللي حضرتك قلته هل متواجد ولا ايه افضل تكنيك؟ يعني
هو اسهل وافضل حاجه دلوقتي البودي كومبوزيشن بتاع الدكسا.
بنكتبها ازاي يا دكتور عمر؟ يعني نطلبها ازاي؟
بودي كومبوزيشن واسسمنت اوف ساركوبينيا، فور اسسمنت اوف ساركوبينيا. اصل البودي كومبوزيشن احيانا بتطلب لاغراض اخرى، فات بقى ديستريبيوشن والناس بتاعت الرجيم والحاجات دي، يعني اصل بيبين فات وبيبين ماسل وبيبين وعظم طبعا. فالبودي كومبوزيشن فور ماسل سترينث او ماسل بالك او فور ساركوبينيا. هو موجود في اغلب المكن يعني المتاح بتاع الدكس، وهو في نفس الوقت اكسسبل وسهل. يعني بدل ما اعمل مثلا سي تي مخصوص للموضوع ده يعني ده اسهل، والليس راديشن.